KJA Global Channel. The Political System and Me. Series 4. The Political System Across Every Sector of Society. Episode 35. Health Sector. Medicine, Ethics, and Equal Life Chances. A nation reveals its true morality when a human body becomes fragile. Not when leaders speak. Not when flags wave. Not when constitutions are praised. But when someone is sick. When a child burns with fever in the middle of the night. When a mother is bleeding and needs urgent care. When an older man's breathing becomes shallow. When a worker collapses from exhaustion. When a family hears the frightening words, "We need surgery." When an outbreak begins and fear spreads faster than medicine. In those moments, politics becomes physical. The political system becomes a question of life and death. Not in theory. In the body. This is where our question begins. When illness arrives, does the health system treat every life as equally worthy of care? Health is not only biology. It is public design, infrastructure, ethics, staffing, budgeting, evidence, trust, law, and either corruption or its defeat. The health sector is not merely technical. It is the living mirror of the social contract. When healthcare is ethical, accessible, and reliable, citizens can feel a deep truth. My country is a home. When healthcare is expensive, corrupt, humiliating, unequal, or broken, citizens feel the opposite. My life matters only if I can pay, connect, or plead. The system reveal is professional health ethics and access. Equal life chances are a democratic commitment tested through ethical, accessible, evidence-based, and accountable health systems. In plain language, the hidden mechanism is professional health ethics and access. Equal life chances do not mean identical health outcomes, because bodies, diseases, and circumstances differ. It means that avoidable suffering should not be distributed according to wealth, status, ethnicity, region, gender, disability, political loyalty, or personal connection. Medicine is not a marketplace of privilege. Health is not charity. Health is not a reward for obedience. Health is a right made real through institutions. Professional ethics begins with a simple moral commitment. The patient is a human being, not a source of profit, a political category, a social burden, or a disposable body. Medical ethics requires respect for dignity, informed consent, confidentiality, competence, honesty, non-discrimination, and care guided by the patient's welfare. Informed consent means a patient should understand the proposed treatment, likely benefits, significant risks, alternatives, and the consequences of refusal where possible. Consent is not meaningful when information is hidden, language is inaccessible, pressure is applied, or the patient is too frightened to ask questions. Confidentiality protects trust. People may avoid testing, treatment, counseling, or reporting abuse if they fear that private information will be exposed. But confidentiality must exist alongside lawful duties to protect others in narrowly defined circumstances. The balance must be governed by clear rules, necessity, proportionality, and professional judgment. Evidence-based medicine is another safeguard. Treatment should follow credible evidence, clinical judgment, patient circumstances, and transparent standards. Evidence does not mean mechanical medicine. It means decisions can be explained, tested, reviewed, and improved. A health system fails when rumor replaces science, politics replaces professional judgment, or commercial influence hides risk. Equal access has at least 3 barriers. The first is financial. Can the patient afford consultation, medicine, transport, testing, treatment, and recovery without catastrophic debt? The second is geographical. Can the patient reach a clinic, hospital, trained worker, ambulance, laboratory, or pharmacy in time? The third is social and institutional. Will the patient be treated fairly, understood, documented, respected, and protected from discrimination, bribery, intimidation, or neglect? A service may exist and remain inaccessible. The building is open but medicine is missing, treatment is free but transport is impossible, or unwritten rules exclude people. Health financing determines who carries risk. When households pay mainly at the moment of illness, sickness can become poverty. When risk is pooled through fair taxation, insurance, or public financing, the burden is shared across society. Financing must be sufficient, equitable, transparent, and sustainable. It must support primary care, hospitals, medicines, prevention, emergency response, mental health, rehabilitation, and public health systems. Health is not only hospitals. Health begins before sickness. Clean water, sanitation, nutrition, safe work, housing, education, vaccination, environmental protection, and early diagnosis often save more lives than late treatment alone. Public health requires trust. During an outbreak, people must believe that information is honest, testing is safe, treatment is fair, and public health restrictions are lawful and proportionate. Secrecy and panic can turn a manageable outbreak into crisis, so public communication must be timely, accurate, understandable, and open about uncertainty. Medicine procurement is where health ethics meets public money. A corrupt contract can remove medicine from thousands of patients. Corruption in health is the cruelest theft because the price is paid in pain, disability, and lives. Procurement must record what was needed, who bid, how the supplier was selected, what price was paid, what quality was required, what arrived, and who verified delivery. Counterfeit, expired, diverted, or overpriced medicine is not merely a market failure. It is an institutional and ethical failure. Health workers carry enormous responsibility and must remain competent, ethical, and accountable. But health workers cannot uphold ethics indefinitely if the system forces them into desperation. Unpaid wages, unsafe workplaces, impossible workloads, missing equipment, political interference, and threats to families can break professional integrity. Protecting health worker dignity is not only employee policy. It is national survival policy. Licensing and professional standards protect patients by defining qualifications, scope of practice, continuing education, ethical duties, and disciplinary procedures. Discipline must be credible and fair. It must protect patients from serious misconduct without turning professional accountability into political punishment or institutional scapegoating. To understand the health sector, follow the rights chain. Right or legitimate interest, law or constitutional rule, responsible institution, complaint or review, hearing and evidence, remedy, enforcement. Right or legitimate interest asks what human claim is at stake. Emergency care, informed consent, confidentiality, non-discrimination, safe medicine, professional treatment, or equal access. Law or constitutional rule asks where the right, duty, eligibility standard, and limit are defined. Responsible institution asks which ministry, hospital, clinic, licensing body, insurer, procurement office, laboratory, or local authority must act. Complaint or review asks where a patient can challenge denial, delay, negligence, corruption, discrimination, unsafe treatment, or breach of confidentiality. Hearing and evidence ask what records exist, who listens, what professional standard applies, and whether the patient can participate safely. Remedy asks what can repair the harm. Urgent care, correction, reimbursement, compensation, disciplinary action, policy change, or restoration of access. Enforcement asks who makes the remedy real and what happens if the responsible institution refuses. A broken outcome may begin far upstream. The visible harm may be a preventable death, missing medicine, an unsafe procedure, a denied referral, an unaffordable bill, or discriminatory treatment. But the deeper failure may be an unjust policy, an unfunded clinic, weak procurement, a hidden record, unlicensed practice, captured oversight, or a complaint process that exists only on paper. The chain prevents us from reducing failure to one doctor, one nurse, or one hospital. It identifies where law, finance, staffing, evidence, ethics, oversight, remedy, or enforcement stopped working. When citizens and professionals locate that break, criticism becomes more accurate and reform becomes more practical. For this episode, the principal mechanism is professional health ethics and access. The production graphic must make every link readable on a phone screen and label country-specific or proposed arrangements honestly. Under dictatorship, the health sector is shaped primarily by concentrated command. Information is restricted, institutions answer upward, health data may be politicized, resources may reward loyalty, and challenge may carry personal risk. Health services may favor the military, ruling network, capital, or politically important areas while neglected communities carry the burden. In a fragile democracy, formal standards may exist while patronage, corruption, unequal capacity, weak licensing, politicized budgets, or poor enforcement makes protection inconsistent. Urban hospitals may improve while rural clinics remain empty, complaints go unanswered, and standards exceed available staff, medicines, or laboratories. In a functioning federal democracy, authority is distributed, common rights remain enforceable, and ministries, hospitals, licensing bodies, courts, auditors, professional associations, patients, media, and civil society can test health power. Comparison is a method of judgment, not a slogan or a ranking exercise. The viewer should compare who decides, how authority was obtained, whether records are public, whether patients and professionals participate, and whether complaint and remedy exist in practice. The democratic design must survive weak leaders, political disagreement, and changes of government. The minimum guardrails are 1. Equal access according to need. Emergency, preventive, primary, specialist, maternal, mental health, disability, and public health services should be allocated by medical need rather than wealth or connection. 2. Evidence-based health policy. Policy should use credible data, professional expertise, ethical review, transparent reasoning, and continuous evaluation. 3. Transparent budgets and medicine procurement. Health revenue, spending, contracts, prices, suppliers, deliveries, stock levels, and audits should create reliable and reviewable records. 4. Professional licensing and ethics. Health workers and facilities need clear qualifications, standards, continuing competence, ethical duties, independent review, and fair discipline. 5. Patient complaint and remedy. Patients need safe routes to report harm, receive reasons, preserve evidence, obtain independent review, and secure enforceable correction. These safeguards work as a system. Access without quality can expose patients to harm. Evidence without funding remains paper. Procurement without records can feed corruption. Ethics without worker protection can collapse under pressure. And a complaint without enforcement does not repair harm. Global relevance. Across political labels, ask who decides, who receives care, what limits authority, what information is public, who can complain, and whether correction is real. Myanmar relevance. Use ordinary lived experience only where it clarifies the mechanism. Do not treat one authority, health system, hospital, organization, community, or proposed arrangement as the whole country. Separate existing institutions from interim systems, local practices, humanitarian services, political commitments, and aspirational federal designs. Here is the civic practice for this episode. See and ask. Identify which access barrier most affects your community, financial, geographical, or social and institutional. Ask who is most affected and why. Verify. Examine a medical ethics code, licensing standard, access policy, financing record, quality indicator, procurement record, or complaint report. Distinguish official policy from what patients and health workers experience in practice. ACT. Apply the health integrity checklist to one service pathway. Examine access, consent, confidentiality, evidence, staffing, cost, medicine supply, records, complaint, and remedy. Identify one professional improvement and one institutional improvement. Use lawful methods and protect patients, health workers, families, confidential records, and medical privacy. Review. Record whether you can name the responsible institution, the evidence, the safeguard or remedy, and one safe next step. The measure of success is not visibility. It is whether you can identify responsibility, evidence, a credible safeguard, and the safest practical action. Equal life chances mean that the political system is not only about who rules. It is about who is protected. It means that when sickness arrives, the citizen does not face it alone, humiliated and desperate. We are a people. We do not abandon each other. That is what makes democracy more than elections. It makes democracy a moral community, a living home. The principle to carry forward is this. Equal life chances are a democratic commitment tested through ethical, accessible, evidence-based, and accountable health systems. Ask yourself, what part of ethical and equal health systems have I treated as normal even though it should be visible, answerable, and correctable? Rights become real through remedies. In the next episode, we continue with public finance sector, budget, procurement, audits, and citizen oversight. Continue the playlist, use the worksheet, and keep the practice safe, truthful, and disciplined. The system shapes our lives. Our participation shapes the system.
Subscribe.
Learn. Participate. Shape the future. KJA. Knowledge justifies authority.